Welcome to the ACE-IT podcast, where we turn science into sense. This is our 12th season of ACE-IT, and we're brought to you via the Justice Community Overdose Innovation Network, or JCOIN. I would like to celebrate a bit this season, for as we start season 12, we've reached 21,000 downloads and counting. Woohoo! Yeah, not because we're famous, certainly not, but because that means at least 21,000 times our listeners have learned something about overdose, opioids, opioid use disorder, medication-assisted treatment, and/or harm reduction. And that, my friends, warms my very grateful heart. Also, just a quick plug for a few other JCOIN features that you might not know about. Did you know you can get technical assistance for your organization from the experts at JCOIN for free? And did you know you can apply for small research grants to help fund innovative study ideas? Yep, through JCOIN. And did you know you can apply to be a JCOIN LEAP scholar or investigator to improve your own skills? Also through JCOIN. If you didn't know about these things, check out our website, jcoinctc.org, and learn about the many JCOIN offerings beyond ACE-IT that may help you learn and grow in ways that improve lives. With that, I'm honored that you're with us. I'm Danielle Rudes, your host, and this is ACE-IT. In this season of the ACE-IT podcast, we're talking all about roles, responsibilities, and reactions to overdose. By that, I mean we're going to examine how people in different environments and different roles prevent and/or react to overdoses. For instance, in our first two episodes, we'll talk about providers' roles in mitigating overdose risks and responding to overdoses. One set of providers are prescribers and pharmacists. The other set of providers are illegal dealers. In later episodes, we'll cover first responders and EMS, law enforcement, emergency room doctors and nurses, prison and jail staff, community correction staff, educational settings and staff, witnesses and bystanders, and finally, harm reduction and social service workers. Today, though, we're going to talk about prescribers, providers, and pharmacist roles, responsibilities, and reactions to overdose. When people think about the current opioid epidemic, many attribute the surge in abuse and overdose cases to the overprescription practices of healthcare providers. In her article entitled DOJ Overreach, The Criminalization of Physicians, London, 2021, traces the evolution of the opioid epidemic, fueled in part by physicians, but, as she argues, more so by the illicit fentanyl market. London takes aim at public and political support for what she deems, quote, invasive prescription monitoring programs, unquote, instead of harsher targeting of illicit drug manufacturers and dealers. As evidence of this claim, London cites national drug data from 1999 to 2019, finding that illegal opioids, for example, fentanyl, are increasingly responsible for more overdose deaths than prescription opioids. In 2019, for instance, prescription opioids caused roughly 15,000 deaths, while fentanyl caused roughly 40,000. So, when we're talking about overdose, and particularly about opioids, we need to consider what type of drug is causing the overdose and who is responsible for providing that drug. Now, since we're talking about providers in this episode, let's review some of the prescription guidelines that have been put in place for medical doctors prescribing opioids to treat pain. There has been a lot of attention on this topic. Recently, drawing on the available scientific evidence and input from advisory committees, doctors, the public, and peer reviewers, the Center for Disease Control and Prevention, or the CDC, published a set of guidelines for prescribers, CDC 2022. Now, there's a lot to unpack here, so I won't get into all of the nitty-gritty details with you, but broadly, the CTC guidelines covered four topic areas. 1, determining whether or not to initiate opioids for pain. 2, selecting opioids and determining opioid dosages. 3, deciding the duration of the initial opioid prescription and conducting follow-up. And 4, assessing risk and addressing potential harms of opioid use. To give more specific examples of one of the CDC's recommendations, the first recommendation under the, quote, determining whether or not to initiate opioids for pain, unquote, topic, is that, quote, clinicians should maximize use of non-pharmacologic and non-opioid pharmacologic therapies as appropriate for the specific condition and patient, and only consider opioid therapy for acute pain if benefits are anticipated to outweigh risks to the patient, unquote. If you're interested in finding out more about the CDC's recommendations, I'll point you to the one-pager for this episode, which contains the reference material for this episode. Okay, so now that we've covered prescribers' responsibilities when it comes to prescribing opioids and preventing abuse and overdose, let's talk a little bit about prescribing overdose reversal drugs, specifically naloxone. Lucky for us, there have been several studies conducted on prescribers and pharmacists' perceptions of naloxone and their willingness to prescribe it. Martino and colleagues in 2020 surveyed 64 physicians and 8 pharmacists and found that the biggest barriers to prescribing naloxone are education and training barriers. That is, 66% of physicians did not receive any training on naloxone counseling, and they had time constraints. A lot of times, physicians and pharmacists felt as though the time it took to counsel patients about naloxone was beyond their capabilities. For example, one physician interviewed by the research team said, quote, I don't offer it very frequently because it takes too much time to educate the patient about it and to describe it to them. There's just not enough time in the emergency department to provide that level of education, unquote. Similarly, Raul and colleagues 2023 interviewed 12 pharmacists about their beliefs in naloxone counseling and found that facilitators to counseling patients about naloxone included receiving naloxone training and having access to counseling guidelines and resources, and that barriers to counseling included concerns about reimbursement, how expensive naloxone was, as well as the patients were generally unaware of naloxone. Interestingly, while pharmacists in this study recognized naloxone counseling as a vital part of their profession to prevent overdose deaths, they also worried about offending patients. Focusing more specifically on pharmacist training regarding overdose and naloxone, Malaragni and colleagues 2019 surveyed pharmacists working in Massachusetts. And the results suggested that most pharmacists did not have a strong understanding about naloxone or overdose prevention. For example, while 52% of pharmacists said it was important to call 911 during an overdose, only 8% knew to start rescue breathing, and only 4% knew to place patients in the recovery position. Regarding knowledge of naloxone, fewer than 50%, that's fewer than half, of the participants knew that different formulations of naloxone possess different quantities. The authors of this study call for increased training requirements in pharmacy schools and by employers. Finally, Lang and colleagues 2024 were interested in what factors made pharmacies more likely to stock naloxone. Their study was based out of Australia and included 530 pharmacies. Roughly 60% of the pharmacies reported stocking naloxone, and chain pharmacies were more likely to stock it than non-chain pharmacies. Again, roughly 60% of pharmacists felt comfortable discussing overdose prevention with patients who use prescription opioids, and this comfort increased the pharmacy's likelihood of stocking naloxone. However, the number of pharmacists who felt comfortable discussing overdose prevention with patients who use illicit opioids was 10% lower. Collectively, this research shows how important pharmacists' ability and willingness to counsel patients on naloxone is, and it shows there is room for policy and practice change in this area. Okay, now that we've covered the roles and responsibilities, let's look at how providers react to a patient's overdose. Now, there has not been a ton of research out there on this topic. There was one study conducted in Scotland that we will talk about, and then there are 2 other articles that we're going to cover that pull from the patient suicide literature. It's basically presenting a call for action for more research on this topic. Let's start with the call to action articles. Ewell and Levin, 2019, published an article titled Supporting Providers After Drug Overdose Death. In this article, they note that, quote, to our knowledge, the provider's experience after drug overdose death has not been studied, and no practice guidelines exist to guide providers after an overdose death, unquote. Then they go on to review the existing literature on patient suicide, including that common emotional reactions by providers, including shock, disbelief, guilt, shame, fear of blame, and self-doubt. Younger doctors also had higher stress than older doctors. They also talked about how working in a solo practice where they are isolated from coworkers can put providers at higher risk of increased stress after the death of a patient. Ermanchi, 2020, wrote a similar piece entitled Bearing Witness to the Epidemic, Supporting Clinicians After a Client Overdose Death. This article reviewed much of the same literature as the previous article, but also included information about helpful coping mechanisms for providers who've lost a client, including prayer and meditation, social support, diversity in professional roles, and relaxation activities. Ermanchi also noted the importance of instilling confidence for providers post-loss, since they might not feel like they did everything they could, or maybe they missed early signs. And now, looking at the study that did actually interview providers following a patient's overdose death, Macaulay and Forsyth 2011 surveyed 65 staff whose patients had died from a drug overdose. Nearly half of the sample worked in healthcare, while the others worked in social services and the voluntary sector. Providers reported that common post-loss emotions included sadness, guilt, and anger. Several factors made people more likely to have stronger emotional reactions to a client's death, including female staff, those with access to more support resources, and those with larger caseloads. Also, those with a greater number of patients who had died from an overdose and those who felt close to that client. From this research, we see how important it is to make sure that providers are also cared for in the aftermath of an overdose-related death. And with that, we've reached the end of our episode on prescribers, providers, and pharmacists' roles, responsibilities, and reactions to overdose. I hope you learned something new today, and I'll catch up with you on the next episode, where we'll be talking about illicit drug manufacturers and drug dealer roles, responsibilities, and reactions to overdose. Thank you for listening to the Aced It podcast. We love hearing from you. So if you have comments, topics to suggest, or some science you'd like us to cover in a future season, please write to me, Danielle Rudes, at Sam Houston State University. My email is drudes, D-R-U-D-E-S, at shsu.edu. And of course, thank you to the Justice Community Overdose Innovation Network, or JCOINS, Coordination and Translation Center, funded by the National Institute on Drug Abuse, housed at George Mason University, where this podcast originated. Thank you to our fabulous scriptwriters and also my fantastic doctoral students, Bryce Kushmerek-McCune and Jalen Magana. And a huge and heartfelt thank you to the team at Slonky LLC for their wonderful production as always. Remember to check out our website, jcoinctc.org, for more cool JCoin features and opportunities. And tune in again soon for another episode of Aced It.